And here is another condition that is sort of a precursor to the maltoma. And here, how would you describe the epithelium here? What is abnormal about the epithelium?
There's loss of polarity and also there's flattering.
Yes, so no foveolar mucin. Yep. And what about these tiny cells?
Intraepithelial lymphocytes.
Yes, yep. So these are lots of intraepithelial lymphocytes. So that makes it look very crowded. And then here, do you see also within the epithelium? Here, these are all intraepithelial lymphocytes. And when they're in the epithelium, the intraepithelial lymphocytes almost look like it has a halo. Do you see that? It has a little halo around it. So these are all intraepithelial lymphocytes. Normally, you shouldn't see more than 20 per 100 foveolar cells. But this is lymphocytic gastritis, where it's gastritis. So chronic inflammation in the stomach is usually plasmacytic. Active inflammation is neutrophilic. Lymphocytic gastritis is too many lymphocytes, not in the lamina propria, but in the epithelium. So here, again, we have way too many lymphocytes. So here is another one with the halo around it. So definitely more than 20 per 100 foveolar cells. And lymphocytic gastritis, you can, it's like reactive gastropathy. There are many conditions that can cause lymphocytic gastritis. So for example, Helicobacter pylori, before becoming maltoma, will look like lymphocytic gastritis. Also, some of the newer immunotherapies, so checkpoint inhibitor therapy can cause lymphocytic gastritis. Drugs can cause lymphocytic gastritis. And here is a CD3 IHC. So here's our control, and it's labeling T cells. And then if you look at the, if you look at the test tissue, you can see that there are way too many T cells in the epithelium. You can see a lot more than you saw with the H&E. So this is a condition of lymphocytic gastritis. Okay, so I think this is the last case we'll stop with. This is a very interesting tumor. Okay, so based on these glands, so where do you think we are? Are we in the fundus? Are we in the antrum?
Antrum.
Yes, we have mucus glands. Correct, we are in the antrum. And then something here is very wrong with the submucosa, right? So here, this is the muscularis mucosae, what I'm drawing here. And you can see that we have a lesion in the submucosa, but it's also coming into the mucosa as well. And let's take a look at this. So how would you describe these cells?
This is just, they look like
Epithelial to spindle cells.
Okay, yes. So there are spindle cells. Okay, and what other cells do you see here?
eosinophils.
Yeah, lots of. Okay, so I heard a gist. So where does the gist come from? What is the cell of origin?
Interstitial cells.
Yes, it
Interstitial
is in,
cells of
and
Graham.
very good. And where are the interstitial cells present? Is it in the submucosa or is it in the muscularis propria?
Muscularis.
Muscularis propria.
Yes. Okay. So this cannot be a gist because it is in the submucosa, right? So if it is a gist, and gist is a very good differential, but the location is not right. A gist will be seen in the muscularis propria, or at least it'll be based in the muscularis mucosa and then it'll infiltrate other areas. But this, do you see, is centered in the submucosa, and in a gist, you typically don't see lots of eosinophils. You don't see too many lymphocytes. So here there are lots of lymphocytes, lots of eosinophils, and so the spindle-shaped cells, those are your neoplastic cells. And then the other thing that is characteristic of this tumor is what we call onion skinning. So here is a vessel, and then do you see how these cells are they are concentrated around the vessel? So it's almost like layers of an onion. So this is what we call onion skinning. And so that is also another characteristic feature of this neoplasm. And so here also you can see it. So do you see that? So this layering of the cells around the vessel. So we have spindle cells, we have eosinophils, we have onion skinning, and this is in the submucosa. So does anyone want to guess what this lesion is?
Sure.
Inflammatory fibroid polyp.
Yes, excellent. This is an IFP, inflammatory fibroid polyp. So the name makes it sound like it's not a neoplasm. It almost sounds like it's a reactive condition. So we used to think that it was reactive, but with molecular studies, we know that there are alterations in the PDGFRA, the platelet-derived growth factor alpha gene. So, so that is the driving mutation, and so this is inflammatory fibroid polyp, and this is a stromal neoplasm. Other names for this are also, Vanek's polyp, but this is a neoplasm. And so, I would still get the gist markers. I would get a CD117, and then, but this one is going to stain. This will light up like a Christmas tree if you do a CD34. So CD34 is for inflammatory for IFP, CD117 dog1 for gist. And then it's also a good idea whenever you see something spindled like this, it's also a good idea to get a S100 or a SOX to rule out schwannoma. But again, yeah. So a schwannoma and gist is going to be in the muscularis propria. So if you're in the submucosa, definitely think of IFP. IFP can be seen in other areas of the GIT as well. So in the small intestine, you can see it as well. Okay, so in the interest of time, let's call it a day. I will stop sharing. Okay. Any questions for you guys? Sorry, I have not been monitoring the chat.
No question in the chat box, ma'am, right now.
Okay. Yeah, okay, great. And so okay, great. Okay. Thank you very much for your participation. Sorry, yes, what was that?
There is one question: how to identify H. pylori apart from being helical?
Yeah. So apart from being helical, you can also do the immunohistochemistry. There are polyclonal IHC, or you can get, you can also do monoclonal IHC. That would be definitive. You can also do PCR or serologic testing. The silver stain, so the Giemsa and the Warthin-Starry, they're not going to be specific. It's useful to see it. You can see if there are helical forms, you can say, okay, this is probably Helicobacter. But if you want to be specific, you can do PCR or you can do serologic testing. But the serologic testing is going to show you, it may not show you active infection. It might show you only, could be past evidence of infection.
One more question, ma'am. Criteria to differentiate neuroendocrine hyperplasia versus carcinoid tumor.
That is a great question. So carcinoid tumor or neuroendocrine, neoplasm neuroendocrine tumor, so there are different criteria. The WHO criteria is different from the CAP criteria. And so, it can be more than 0.05 is one of the criteria. Other folks also, so here typically what we do is, if it is a mass lesion, if it is infiltrating into the beyond the muscularis mucosae or into the muscularis, or if the endoscopist has seen a mass. So if the endoscopist sees a polyp and you see neuroendocrine hyperplasia, it's better to call it a neuroendocrine tumor. So there's the size cutoff, and also, more practically speaking, if it is only incidentally noted, if you're only seeing it on microscopy, better to call it hyperplasia. But if the endoscopist saw it, better to call it neuroendocrine tumor.
Ma'am, one more question. Sometimes the regenerative epithelium show the atypia. How to differentiate it from the dysplasia?
Okay, so let me actually share this. Okay, we are now, let's go back to so this what I mentioned about the 4 lines, that can be a useful trick. So this here, so this top line, so that is line number 1, which is the apical mucin, and line number 2 is the base of the mucin. Line number 3 is the cytoplasm, and line number 4 is the nucleus. So if you draw along like this, you'll see that, these are all quite regular. They have, they're quite well organized. So these are called the 4 lines. And if you look at a case of dysplasia, do you see here, we don't have any, first of all, we don't have the first line. There's no apical mucin, right? So we only have the cytoplasm. And then if you look at the line 4, which is the nuclear line, you see it's going from, it's not a straight line, right? It's kind of like jumbled all the way. So this disorganization of the lines is what you see in dysplasia. On the other hand, when you have infection or a reactive condition, even though there are some changes, I'm trying to find some inflamed areas here. Let's see. All of this is dysplastic. But basically, when you have a reactive condition, the lines are still somewhat maintained. So you can use the lines. Look, so for here, for example, again, you don't have line 1, you don't have line 2, and line 3, you can see that the nuclei are all, it's going to be a jagged line. So you can use the 4 lines to help distinguish between dysplasia and reactive conditions. And then sometimes it's simply not possible. So you in that case where it's not possible to differentiate, we use the we say indefinite for dysplasia, right? So when you say indefinite for dysplasia, then you can also tell the surgeon, okay, there's a lot of inflammation. I don't know if this is reactive or dysplastic. So at that, maybe they'll wait for the inflammation to subside. They'll call the patient back in 3 months or 4 or 6 months and repeat the biopsy. So at that time, it usually resolves itself one way or the other. It's sorry, so the cutoff is 0.05. Some institutions also use 0.02. Practically speaking, I just find it easier to, if they saw a mass, I call it tumor. If they didn't see a mass, I call it hyperplasia. I'll put in a comment and I'll say it is not possible to definitively differentiate between hyperplasia and neoplasm. Close surveillance is recommended.
Thank you, ma'am.
Of
It
course.
was a wonderful session.
And thank you so much, especially to the residents who did a great job describing. And thank you so